I'm turning on the recording. This meeting is being recorded, so I want to bring that to everybody's attention. After the conclusion of the meeting, within a few days, it will be posted to the OHA's website. Um, as I mentioned at the top of the order, we do have a new appointment to the P&T committee. Want to lead off with roll call and introductions. For those members who are in the audience, a packet of materials has been posted to our website, along with the written testimony that was submitted for the committee's consideration, as well as a couple consent agenda items. We have a P&T annual report, CMS annual report, and the full DERP summary that we've summarized we're presenting. So I want to lead off kind of in reverse order because we really appreciate Dr. Jeannie Savage, the medical director of Trillium, throwing her hat in the ring and being appointed by the OHA to join the committee. So we have now a full slate, 5 physicians, 4 pharmacists, and 2 that are neither physicians or pharmacists. But Dr. Savage, can I let you lead off with an introduction just so the committee can get familiar, and then we'll go down through the rest of the order.
Absolutely. Good afternoon, everybody. Jeannie Savage, I use she and her pronouns. I am the Chief Medical Officer for Trillium Community Health Plan, and I am also a family medicine and OB provider physician at Salud Medical Center in Woodburn. I've been there for about 20 years, and I've been in my current role as well as the CMO for Trillium for about the past 5 years. And I'm really excited to join this group. I feel like I have a lot to learn from everybody, and I'm just excited to be part of this. So thank you.
Well, we really appreciate it. So welcome. Doug, let's let you lead off the rest of the introductions. You're at the top of the alphabetical order.
I'm Doug Carr. I'm an internist from Roseburg, Oregon. I am the medical director at Umpqua Health.
Welcome, Doug. Russ?
Hey, this is Russ Huffman. I am a psychiatric nurse practitioner at Salem Health.
Welcome, Russ. Dr. Anishi was not able to join us today, so Eddie will turn to you.
Hi, Eddie Saito. I am associate professor at Pacific University School of Pharmacy and a clinical pharmacist at Virginia Garcia Memorial Health Center.
Welcome, Eddie. And Pat?
Pat DiMartino. I'm a pediatrician at OHSU in the division of HEMOC.
Welcome, Pat. Kat isn't able to join us, so Stacy will turn to you.
Hi, and welcome, everybody. My name is Stacy Ramirez. I am a primary care pharmacist and the director of pharmacy at the community health centers of Benton and Lynn counties, and a clinical assistant professor for OSU.
Welcome, Stacy. Tim?
Good afternoon. This is Tim Langford. I'm the pharmacy director with the Klamath Tribes in Klamath County, Oregon.
Welcome, Tim. Bridget?
Yeah, my name is Bridget Bradley. I'm a psychiatric pharmacist at OHSU.
Welcome. Samara?
Yeah, hi, I'm Samara Stevens. I'm a naturopathic physician in private practice in Portland.
Welcome. And Jeannie, we had your introduction, so we're going to turn it over now to staff. Jennifer, I think I saw you, so we'll let you lead off.
Jennifer Bowen, executive assistant with the Oregon Health Authority.
Roger Citron, I'm the director of the Drug Use Research and Management Program, and we provide the clinical support, pharmaceutical support to the OHA. Trevor's pulled in multiple directions, so Dave, will turn it over to you.
All right. Hi, I'm Dave Engen, clinical pharmacist with the OSU Derm team.
Hi, I'm Sarah Fletcher. I'm one of the clinical co-coordinators with the OSU Derm team.
Hi, I'm Andrew Gibler. I am the clinical pharmacy manager for the Oregon Health Authority.
Kyle and Dan aren't with us today, so Megan will turn to you.
Hello, I'm Megan Herring, a clinical pharmacist with the Derm team.
Good afternoon. I'm Deanna Moretz. I'm with the Derm team.
I'm Kathy Centena, and I am also a clinical pharmacist with the OSU Derm team.
Hi, my name is Sarah Serbid. I am one of the P&T clinical co-coordinators with the Derm group.
Hi, I'm Lance Starkweather. I'm pharmacy manager for Gainwell Technologies.
I'm Dee Weston, pharmacy program policy advisor with OHA.
And I'm Brandon Wells. I'm the pharmacy program analyst for the fee-for-service program at OHA.
Welcome. So next on the agenda, we have the approval of the agenda and the minutes. I sent out the minutes to the committee to be able to review in advance. So if you're following along in the packet of materials, those start on page 4 for the posted packet. So are there any edits that the committee would like to recommend? And if not, we would entertain a motion to approve.
Motion to approve.
Second.
Thank you, Doug and Russ.
All those in favor?
Aye.
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 Anyone opposed? Abstain? All right, thank you.
And I am going to take myself off of video just because it's quite distracting. So I'll try to join back with my video later. So at this point, we're going to turn it over to Andrew Gibbler to provide the department update.
Thank you, Roger. We have four openings on the P&T committee at the end of the year as their terms expire, and we're very thankful each one of them has reapplied and still waiting for a couple of CVs or current CVs or resumes. So please submit those when you can. We'll continue to have those positions open for applicants until October 8th. And so if others are interested to apply, we've got two physician seats, a public seat and a pharmacist seat, but really appreciate that those that are currently serving continue to desire to serve, and we appreciate very much their contributions. So we will continue to work towards that endeavor and get those appointments approved by the end of the year when the terms expire. So also just again want to thank on behalf of OHA everyone's service volunteering on this committee. I know it's a lot of time and work just to read all the material before the meetings. It's really appreciated, and it's a wonderful service that you're providing to the state and to the Medicaid program. So we appreciate it. And I don't have anything else at this time that I can think of to share. So I'm going to send it back to you, Roger.
Appreciate it, Andrew. So one additional announcement that I wish to make, I'm going to hold off for that. So next up, we're going to the consent agenda. So as I mentioned, the P&T annual report and the CMS annual report, one is made for CMS annually. It reflects the work this P&T committee has performed. The P&T annual report similarly outlines the work and some of the cost effectiveness of this committee that's being prepared to be presented to the legislature later in the year. Those are part of the consent agenda. And so just wanted to bring you to attention. So if the committee wished to have any of those topics pulled off to discuss, we can do so. If not, the recommendations are to review the pricing for the hepatitis and insulins in exec session, but otherwise to have our standing policies for the addition of agents to the oncology and orphan drug policies. So if the committee is okay with these being on the consent, we'd entertain a motion to approve.
Motion to approve.
Thank you, Pat.
Second.
Appreciate it, Doug.
Thanks, Doug. All those in favor?
Aye.
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 Anyone opposed? Abstain? All right, consent agenda is approved.
I was a little ahead of myself. I'm kind of distracted. I missed kind of talking about and stressing the importance of conflict of interest. So for the public to be aware, all of the staff certainly have conflicts of interest declarations on file with the OHA, as do all of the P&T committee members, and anybody wishing to provide public comment today fills out one of our forms, and I'll detail that as they are permitted their 3 minutes. So we do at this time offer to the committee to disclose any recent or new conflicts of interest that they might want to disclose to the OHA. But I just wanted to bring that. It's an important topic and wanted to make sure that was on the recording. So anybody on the committee have any additional conflicts that they need to bring forward? Assuming I didn't hear any, I just wanted to reiterate that. So thank you. So we're now going to turn to page 63 if you're following in the packet for the DUR new business. We have the immunoglobulin drug use evaluation, and I'm going to turn it over to Kathy Centena to lead off.
Great, thanks, Roger. So yeah, I did a lit scan on immunoglobulins, and the purpose of this was to look at any new evidence published since the last review done in June of 2021. We also had an emphasis put on evidence for off-label uses of the immunoglobulin products to determine if the coverage for these purposes should be approved. A little background on that. In general, there's just low quality evidence for a lot of these off-label indications that immunoglobulins are used for. But they just haven't been extensively studied. So we looked specifically at evidence for those because Sarah will be talking about this a little bit next. But currently, we don't have a pathway for coverage of these non-preferred immunoglobulin products for these off-label uses that do have some evidence of benefit. Additionally, just a little background on immunoglobulins. They all have the same active ingredient marketed under different brand names. Prior reviews haven't found any evidence to suggest major differences in efficacy between the products. These are available IV or sub-Q. Some products are indicated for both routes of administration, and they do come in different concentrations ranging from 5% to 20%, most commonly used in the 10 and 20%. And the sub-Q products do allow a little bit more flexibility in that some patients trained to use these are able to do so at home. The products also differ a little bit in content, pH, and stabilizers that we'll touch on just a little bit, but for the most part, pretty similar. So for this lit scan, I did identify 4 new systematic reviews and meta-analyses, 1 new guideline, 3 new indications, 5 new formulations, and 1 new randomized clinical trial. So moving on to the systematic reviews, these were all done by Cochrane. The first one was looking at IVIG in chronic inflammatory demyelinating polyradicular neuropathies. I'll just refer to that to CIDP. This is a weakness and numbness of the limbs that can be progressive or relapsing and lasts over 2 months. And so how Cochrane evaluated the disability score was to look at the inflammatory neuropathy cause and treatment disability score, the modified Rankin scale, and the overall neuropathy limitation scale. So that's what was used to come to their conclusions. And what they found was that IVIG was more effective than placebo for improving disability at 6 weeks, within 6 weeks of starting treatment, with a number needed to benefit of 4. And this was based on high quality evidence. They did not find a significant difference between the immunoglobulins and prednisone based on moderate quality evidence. And they found that methylprednisolone was actually more effective than IVIG at improving disability at 6 weeks. A second Cochrane review looked at the IVIG for Kawasaki disease. And as you all know, that's a rare heart condition causing inflammation of the blood vessels and high fever, most commonly seen in infants and young children. So the outcome used for this was a coronary artery abnormalities. And they found that IVIG was actually more effective than placebo for reducing the incidence of CAAs compared to aspirin, and that the higher doses were actually more effective than the moderate or low doses. The third systematic review was looking at presumed viral myocarditis in children and adults, and there was just very low quality evidence that immunoglobulins may improve survival compared to placebo in this population, but the results were not statistically significant. And then the last Cochrane review looked at multifocal motor neuropathy, which is another rare disorder causing weakness in one or more limbs that's progressive and has minimal treatment options. Again, there wasn't a lot of evidence, but it did find that IVIG may improve disability and strength, but the evidence was of low quality and of actually very low quality when they looked at the sub-Q administration route. For guidelines, we just had 1 guideline from the American College of Rheumatology, and they looked at treatment for interstitial lung disease in adults. And they do conditionally recommend the use of immunoglobulins for those patients with idiopathic inflammatory myopathies and mixed connective tissue disorders that have progressive disease despite first-line treatments, as well as in those patients with rapidly progressive ILD. Moving on to the new indications, we have 3. The first one's for HyQvia. It's a sub-Q administration product that was approved for primary immunodeficiency. We refer to just PI. This is the most common indication used for or sought by immunoglobulins for approval. And so it was approved in this population for adults and pediatric patients 2 years and older. GammaGuard liquid, which is administer IV or sub-Q, was approved for the additional indication of CIDP to prove neuromuscular disability and impairment in adult patients. And this one is a little unique in that it doesn't have any added sugar, sodium, or preservatives. So sometimes this is one of the immunoglobulins recommended for those that are diabetic. And then the last one was Bivigam, again, an IV preparation approved for a new indication for the treatment of adults and pediatric patients 2 years and older with PI. We have 5 new formulations. The first one is Alleglo, which is immunoglobulin approved for the treatment of PI in adults. This one uses cation exchange chromatography to remove coagulation factors, which clinically, the value of this is unknown, but that's something a little bit unique about this formulation. The second product, Cuticig, it's a sub-Q formulation, again, in that 16.5% solution concentration, which this is the only immunoglobulin that actually comes in this concentration. And it is approved for use in adults and pediatric patients 2 years of age and older with PI. There's Asenaviv, which is another IV immunoglobulin approved for PI in adults and adolescents. Panzyga, again, another IV preparation approved for patients 2 years and older and those with ITP, CIDP, and PI. And then the last one is a subcutaneous preparation, Zembify, in which it's approved for the treatment of PI in patients 2 years and older. And this is a 20%, so higher concentration, and it doesn't require initial IV treatment, and it also allows for biweekly dosing. Moving on to the randomized controlled trial, this was done with the IVIG Octagam 10%. This was given every 4 weeks compared to placebo in adult patients with dermatomyositis, which is a rare kind of long-term inflammatory disorder that affects skin and muscles. And what they looked at 16 weeks was the response, which was defined as a total improvement score of at least 20, indicating minimal improvement at that time point. So it did show that IVIG was significantly more effective than placebo with a number needed to treat of 3. So the recommendations for this class are no changes to the PDL based on the review of this new evidence, and to implement prior authorization criteria for these non-preferred pharmacy claims used for these off-label indications, but Sarah will touch on that much more in the next presentation, and then evaluate medication costs in executive session. And at this time, I'll take any questions, or do we want to wait till the end, Roger, after Sarah presents?
Yeah, no, great job. Any questions for Kathy for the information that she presented? Yeah, and we'll hold off, see if there's any questions after Sarah's portion, and then we'll take the recommendations.
Thanks.
Again.
So I'll go ahead and touch on utilization of our IVIG products a little bit. We did this drug use evaluation because our current policy applies primarily to pharmacy claims. We just have preferred and non-preferred products, and the non-preferred products require PA with our general non-preferred PA criteria, which limits use to FDA-approved indications. So there's no route to approval for non-preferred products or a point-of-sale pharmacy for off-label indications. A lot of our claims do go through the medical benefit, which are not reviewed for PA or for FDA-approved indications. And so this analysis was looking at how much utilization we have for off-label diagnosis through the pharmacy and medical benefits, and then whether those differences in policy, how they impact pharmacy claims through the pharmacy and medical benefits. So the population that we looked at was members with paid or denied fee-for-service pharmacy claims or medical claims for IgG. We looked at a 2-year window. from the beginning of 2022 to the end of 2023. That main outcomes that we were looking at were people who had an FDA-approved indication in their medical claims or some other off-label evidence-supported indication in their medical claims. And then we also looked at follow-up for members with an initial denied pharmacy claim, looking in the following few months to see if they had a subsequent paid claim for IgG. We identified about 100 people who had fee-for-service Medicaid claims through the medical or pharmacy benefit. Only 35 people of those fee-for-service Medicaid was the primary payer. So we had lots of people on Medicare and with other primary insurance who were getting IgG, and those people weren't included in this analysis. Medical billing was more common than pharmacy billing, so 26 of those members had claims to the medical benefit, and then denied claims were more common for, or I should say initial denied claims were more common through the pharmacy benefit for those non-preferred products. They stopped for PA, and that was accounted for 9 members. So this slide shows the most common diagnoses that we identified for these members. You can see they're divided out into indications for which at least one IVIG or IgG product has FDA-approved indication, and then other off-label indications for which there is some evidence is shown below. Almost 69% of members had an FDA-approved indication, so the majority of members look like they were using the IgG on label. About 22% or 23% of members had some other off-label indication in their medical claims. And then this shows the breakout of members with denied index event. And like I said, this does only apply to pharmacy claims because the medical claims don't stop for PA. There were 9 members that had a initial denied index event. Most of those members, 3 of them had a subsequent paid claim for members with an FDA-approved indication. 1 member had a subsequent paid claim that had another off-label diagnosis. And then 5 members were either subsequently enrolled in a CCO who might have paid for the IgG or had other active insurance that might have paid for the IgG. So based on this, because most of our utilization does appear to be appropriate based on the diagnosis, we did want to implement the PA for non-preferred products through the pharmacy benefit to support off-label use of IgG for evidence-supported diagnoses. And I'll go through that criteria here. We're proposing putting together a table of common FDA-approved indications or compendia-supported indications based on whether they've got evidence in adult or pediatric patients. And so that's included in the PA criteria. And then this slide outlines the questions in our initial approval criteria. We essentially ask whether the provider will switch to a preferred product, if the request is for an FDA-approved indication or an off-label indication that has evidence of efficacy that's listed in the table above, they could get an approval in question number 4. If it's not, so it's another off-label indication that isn't listed in the table, they could get an approval if the request is for continuation after a hospital discharge in question number 5, or when the request is written by a relevant specialist, so a neurologist, a transplant provider, infectious disease, or other relevant specialist. They can get an approval if it's a short-term treatment, or if it's long-term treatment, if they've got documentation of disease severity and evidence of medical benefit that they submit with the PA request. And then as far as our renewal criteria, we're just basically asking them to document evidence of clinically meaningful improvement in symptoms, functions, disease severity since they started the IgG, and then they can get another approval for a year. So questions on the data that I presented or the PA criteria?
And I have a question, Sarah. So if it's for a preferred product, this kind of PA criteria doesn't apply, and then we presumably have a preferred product that's IV and then one sub-Q kind of thing?
We only have one preferred product currently, but one of our recommendations is to look at cost in executive session. Historically, not a lot of our IV use goes through point of sale pharmacy.
Oh yeah, fair.
But I mean, that's a relevant point. I mean, just to have at least one sub-Q or IV available might be reasonable.
No, that totally makes sense. Yeah, I think you guys walked the line really nicely with this PA criteria. Yeah, I like it.
Other questions?
Nice job, Sarah, as well. We do not have anybody that signed up for public comment. So the recommendations are here on the screen. Again, based on the clinical evidence, no changes to the PDL are being recommended. And we'd like to implement the PA criteria for the non-preferred IgG agents that are being billed through the pharmacy benefit. And that'll allow the appropriate use for both on and off label and supported diagnosis. Then we're going to look at pricing in exec session.
I move for approval.
Thank you, Doug.
Second.
Appreciate it, Pat.
All right, all those in favor?
Aye.
Aye. Aye.
Aye.
Anyone opposed? Abstain? All right, thank you.
Great. Next, again, following in the packet on the blib, we'll turn your attention to page 92. We have the DERP summary for the MS report, and turn it over to Deanna Moretz.
Thank you, Roger. And we are on page 92 of the packet. We could go to the next slide. So as Roger mentioned, this is a report from the Drug Effectiveness Review Project, who is based at OHSU. Next slide, please. Just for some background, I wanted to share that these are all the different medicines that are approved for treatment of MS. They're divided into oral and injectable. As you can see, most of the agents are approved in relapsing forms of MS. Only Ocrevus, the one that's highlighted, is approved to use in primary progressive. It's the only monoclonal antibody that has approval for that. These drugs mostly vary in how potent they are, and they all have adverse side effects. If you refer to Appendix 2, that's on page 103, there's more details about the different side effects for the different medications. We could go to the next slide. So early use of the disease-modifying drugs is recommended in patients that have relapsing forms of MS because it's shown to reduce the frequency of relapses, lessen the severity of relapses, and slow disability progression. Most of the availability of evidence is based on a limited number of comparative randomized controlled trials, indirect cross-trial comparisons, and observational studies. And these studies suggest that the monoclonal antibodies have the highest efficacy to treat relapsing forms of MS, including cladribine, which is not a monoclonal antibody, but it is a very potent. And then intermediate efficacy is the S1P receptor modulators, the fumarates, and teriflunomide. And then finally, the lowest efficacy, but perhaps the best tolerated, are the interferons and glatiramer. Next slide, please. So since we last reviewed MS in 2020, which was also based on a DERP report, The findings from the 11 previously reviewed head-to-head comparative trials have not changed. In the new DERP report from 2024, they identified 6 new head-to-head comparative trials that were conducted in adults. For 5 of the randomized control trials, oral teriflunomide was the active comparator, looking at, all right, I'm going to mangle these names, ofatumumab, which is also Kesimpta, oral ponesimide, which is Ponvari, and then a new IV product, ublixituximab, which is Bremvi. So those are 3 new drugs that we haven't previously reviewed before. And then there was one randomized control that looked at oral fingolimide with subcutaneous gluteramine. Next slide, please. So just to summarize the findings, when they looked at oral teriflunomide with sub-Q ofatumumab, the annualized relapse rate, which is a lot of times that's the primary efficacy endpoint, they showed a mean difference of 0.13 between the 2 drugs. Just as a reminder, in general, a change in the relapse rate of 0.4 to 0.6 is generally considered significant. So there was a statistical significance, but in terms of what's the clinical significance of a moderate change like that, a very minimal change, that's debatable. And then they also looked at the risk of disability worsening using the expanded disability score. And you can see the difference there. That was moderate certainty of evidence. And then they showed no difference in disability improvement at 6 months. Similar results were noticed when they looked at oral teriflunomide versus oral ponesimide. Again, the annualized relapse rate, very small change, but it was considered statistically significant, perhaps not clinically significant. And then there was no differences in the changes in disability based on very low quality evidence or the serious adverse events. Next slide, please. And then when they looked at the oral teriflunomide versus this new ublixituximab, again, there was a difference in the annualized relapse rate. It was decreased. And this was based on a meta-analysis of 2 randomized control trials, moderate certainty of evidence. They did see more serious adverse events with the IV product versus the oral product, low certainty of evidence for that. And then the last study was the oral fingolimide versus the sub-Q gluteramine. And fingolimide was better at reducing relapse rates compared to gluteramide, and it also improved the functional disability compared to gluteramine, as assessed by the multiple sclerosis functional composite score. There was no difference in the annualized relapse rate or change in function when they looked at the lower dose of fingolimide. Next slide, please. So based on that evidence, our recommendation is to maintain ublituximab as non-preferred on our PDL, and then add ublixituximab to the PA criteria. We had already added the other 2 agents to our PA criteria, and we will look at drug costs in exec session. So the remainder of the presentation will just go through the changes in the PA criteria. So the first thing on this page, most of our changes in the PA criteria were to reduce barriers to patients getting MS drugs. So the first thing we did on this page was change the length of authorization from 6 months to 12 months. And please note that Tisabri or natalizumab has separate PA criteria, as does the ofatumumab. There's a branded product that's only used for certain types of cancer, so that's reviewed under the oncology PA. Next slide, please. So the biggest change was to remove question 7, which is asking if the patient has tried and failed 2 other drugs. We realized that some of these monoclonal antibodies might be considered first line if someone has very active MS. So we wanted to reduce the barrier. And then we added ublixituximab to question 8 because it does have teratogenic risks. Next slide, please. And then for the renewal criteria, we had said that has the patient improved as assessed by the physician? And we needed to acknowledge that people with MS don't necessarily improve. Just no disease progression is often a sign that the disease is under control, that the condition's being stabilized. So we used wording that came from one of the advocacy groups recommended that we suggest that the disease is stabilized using those indicators there, or that there's minimal or no disease progression. So those were the changes to the injectable PA criteria. Next slide. I think we did add, we added Briumvi or ublituximab to the safety. This is the FDA approved indication. So right now it's only approved for relapsing forms of MS. And then the next slide, we added it to the safety assessments. And those safety assessments come from the prescribing information. We had put in the pregnancy assessment as well, which is standard language for our PA criteria. And I believe that is all we had for the injectable PAs. Yep. So for the oral PAs, same thing. The oral medicines, we changed the length of authorization from 6 to 12 months. No changes to the oral drugs because there weren't any new drugs that were added. And then next slide, please. No changes to these first 6 questions, just asking what's the diagnosis? Have they tried other agents? In particular, ozanimod is also approved for ulcerative colitis, so those questions are asking about that. And then is it the appropriate age range, and is it being prescribed by or in consultation with a neurologist or a gastroenterologist if it's for ulcerative colitis? On the next page, I wanted to highlight, we consolidated, there were quite a number of questions in the PA criteria and it had gotten very long. So we've been trying to use these tables to put all of the safety assessments in one spot and just have one question that says, have the safety assessments been assessed? So what we did is we removed questions that referred to looking at the CBC or asking for the ophthalmic exam. So that's why those 2 columns are highlighted. And then if you go to the next slide, so these are the questions that we removed. We had asked about teratogenicity in 2 separate sections. So we moved it all to be in one section. We took away the question that asked about macular edema and put that into the ophthalmic section. And then on the next slide, in the packet, question 14, there was an error when we were making all these changes and the fumarates got added by mistake. The fumarates don't have teratogenetic possibilities. So it's just the cladribine that we wanted to assess for teratogenicity in terms of the oral medicines. So we cleaned that up. And then we took out the question about CBC that we had before. And then the next slide is the renewal criteria. So again, we revised the renewal criteria to reflect the fact that we might not necessarily see improvement with MS, but that the relapses are not progressing or that their condition is stabilized. So with that, I will open it up to any questions from the P&T committee about the changes to our PA criteria.
Hey, Dan, it's Stacy. I just have one quick question. I think I know the answer, but if you can just go back one slide to that PA criteria. So an MRI is not required. It's just one of the ways that the provider could demonstrate either stability or lack of progression, correct? Okay, perfect.
Exactly. It's just, we instead of just saying stabilized,
right,
we wanted to put some examples. And like I said, this verbiage came from the written testimony from one of the advocacy groups. I don't know if you had a chance to read the written testimony. I think we had written testimony from 3 separate groups. So they had put that language in there and that looked very reasonable. So we just added it to the renewal criteria.
No, I totally agree. I just wanted to make sure I was
to confirm. Yes, it's not right. It's not required.
Perfect. Thank you.
Deanna, good job on this, cleaning things up. This is hard to to streamline. So just one question. On ocrelizumab, there have been cases of PML reported. And so I know it hasn't prompted the FDA to create a black box. And I'm assuming that most of the time JC antibodies are evaluated, but should it not be part of your screening criteria since that has occurred?
I thought we had the baseline assessment for, we could add it to that table too, if, right there under
Yeah,
ocrelizumab.
JC, similar to what you have for natalizumab.
Yeah, we could just add assessment for the JCV virus.
I think that's just
That's a good
demonstrating
idea.
our recognition. I mean, to recognize it and then not mention it. I think that probably, I think most people are doing it, but it's something that we should probably do.
Yeah, I totally agree. And thank you for pointing out that observation. And I want to point out this was a team effort. I did not do all this by myself. So we had a lot of input, not only from the advocacy groups, but from the team too. So yeah, anytime we can streamline the PA criteria, I think that makes it a lot easier for Gainwell to do the prior authorization assessments.
Great.
Yeah, thank you for pointing that out. Any other comments or questions?
And we do have public comment.
So I'll turn it back to you, Roger, so you
You
can.
bet. And we'll leave room
on.
for questions from the committee after that. So
Thanks.
let me find the apologies. I'm juggling too many things here.
You trying to find the timer and the list?
Well, I've got the timer up. I just
Okay.
needed to make the public commenters co-hosts. So we're going to start with Shirley Quach from Novartis. Shirley, are you able to unmute your line?
Yes, can you hear me okay?
Can hear you loud and clear. I am going to share my timer. Are you able to see that?
I don't see it. Or actually it's okay. I see it now.
Yeah.
Fantastic. With that, the floor is yours.
Great. Thank you. Well, good afternoon, committee members. My name is Shirley Quach. I'm a value evidence lead with Novartis. I just want to thank you for this opportunity to provide updated information on Kesimpta, and Novartis respectfully requests that the committee considers adding Kesimpta as preferred on the PDL. As Deanna mentioned, Kesimpta is a fully human anti-CD20 monoclonal antibody that's self-administered, approved for adult patients with relapsing multiple sclerosis or RMS. We now have 6-year long-term data from the Alithio's phase 3B open-label study evaluating the safety, tolerability, and effectiveness of Kesimpta in patients who participated in the Kesimpta clinical MS studies, such as the phase 3 pivotal trials and the phase 2 trials. Over the 6 years, continuous Kesimpta was associated with 44% fewer overall relapses than patients who switched from teriflunomide in the core study to Kesimpta. There were very low relapse rates corresponding to about 1 relapse every 20 years, sustained reduction in brain lesions, and fewer 3-month and 6-month confirmed disability worsening events. In the switch groups, patients who switch from teriflunomide to Kesimpta after the core period, improvements across several efficacy outcomes were seen after switching to Kesimpta. However, the rates of 3- and 6-month confirmed disability worsening events remained higher compared to those patients who received continuous Kesimpta, indicating that the efficacy benefit of first-line Kesimpta on delaying disability worsening was not fully achieved in the switch group. Cumulative safety data for up to 6 years show no new safety risk identified and suggest that extending Kesimpta treatment is well tolerated in RMS patients. With Kesimpta, it does have the power, precision, and flexibility to help MS patients control their disease and offers a highly efficacious self-administered B-cell therapy with a tolerable safety profile. Again, Novartis respectfully requests that the committee considers adding Kesimpta as a preferred agent on the PDL. Thank you for your time and consideration, and I'm happy to address any questions you have for me.
Thank you, Shirley. Questions from the committee for Shirley? All right, thank you. Next, we have Lisa Carmen with Genentech. Lisa, are you able to unmute your line?
Hello, good afternoon. Can you hear me?
Can hear you loud and clear.
Hi,
And with
thank
that, the
you.
floor is yours.
Well, thank you. I wanted to reserve the right through testimony, and the draft changes is what we had expected. So I want to yield time back to the committee unless you had any other questions for me regarding Ocrevus. Hearing nothing, I yield my time back.
Appreciate you yielding the time back. If we had any other questions that come up, we'll refer back to you, but appreciate your respecting the committee. And finally, we have Linda Finch from Biogen. Linda, are you able to unmute your line?
I am. Can you hear me?
Loud and clear. And with that, the floor is yours.
Thank you, Roger. So good afternoon. I'm Linda Finch. I'm a medical account director with Biogen. I'll be discussing natalizumab or Tysabri today. I've supported Tysabri along with Biogen's portfolio of MS therapies for over 17 years now. And over that period of time, there's been a significant shift in how MS is treated. And there's now a large number of therapies available to treat MS, as you have seen from this DERP report. And I do applaud the changes. You didn't mention Tysabri, and I know there's a separate PA, so I want to specifically talk about that. Tysabri remains a really critical tool for neurologists, especially for rapidly stabilizing patients with highly active or aggressive MS, and for treating patients with MS-related cognitive impairment. The patients treated with Tysabri have experienced clinically meaningful improvements in cognitive tests. And the risk mitigation strategies for Tysabri have also continuously evolved, and neurologists can now identify who's at highest risk of PML and reduce that risk through the use of tools that we've developed, such as JC virus testing, JCV index assessment, and extended interval dosing, which has significantly reduced the risk of PML even in JCV positive individuals. During the COVID-19 pandemic, other attributes of Tysabri, such as preserved response to vaccines and its mechanism, which doesn't deplete lymphocytes, have made Tysabri an essential first-line option amongst the high-efficacy therapies. So MS therapies which deplete lymphocytes led to more severe COVID-19 and a higher risk of hospitalization during the pandemic. And MS therapies which impact the response to immunization, such as S1P inhibitors and B-cell depleters, present a challenge and a significant dilemma in our post-pandemic era where regular vaccine boosters are needed. Your current criteria require that MS patients try and fail 2 therapies prior to using Tysabri, and these criteria don't account for the heterogeneity of MS, and that some patients have aggressive disease early on. They can sustain permanent disability with each relapse, and cognitive impairment can begin early in the disease course and can be even more disabling than physical disability. So patients with highly active MS can't afford to try and fail less effective therapies before stabilizing their disease. Failing a less effective therapy means that patient has ongoing disease activity and could sustain permanent neurologic disability. So while you may allow for medical exceptions, that does take time. And in MS, time loss equals brain cells loss. So the CMSC guidelines support use of Tysabri as an option for early aggressive disease. And then AAN guidelines also recommend Tysabri or another high-efficacy DMT for people with highly active MS. So I respectfully request that Oregon Medicaid follow these national guidelines for the treatment of MS and allow the use of Tysabri as a first-line option for patients with highly active or aggressive disease, including manifestation of MS-related cognitive impairment. Thank you very much for your time, and I'm happy to take any questions.
I will comment, Linda, that I looked at most recent guidelines, and NICE has not updated their Tysabri guidelines since 2007. There are neurology guidelines that were updated in 2019. Sarah, I don't know if it's possible to bring up the Tysabri PA criteria. They're on page 116 of the packet. But I would ask the P&T committee maybe to discuss, is question 4 trial and failure of 2 drugs prior to use of Tysabri still appropriate? Or should we leave it to the neurologist, and if they want to use Tysabri first line, remove that barrier? I would open that to the P&T for discussion.
Does anybody have any opinions, thoughts?
There's the PA.
My
Thank you, Sarah, for bringing up the PA criteria.
my inclination would be that like utilization is probably not huge, and I would maybe err towards more leeway for the neurologist. Though, yeah, don't feel strongly.
So you would potentially advocate
Drop.
for removing question 4?
Yeah.
What about, is there, so is Tisabri though is primarily going to be used first line in more severe disease, correct? So is there some way that we could capture that in the PI criteria that isn't 2 failures? Or is that making it more complicated than it needs to be?
I would advocate that the neurologist is going to be the best one to identify if somebody has active MS that warrants treatment with Tisabri. And we do have number 5 there, that is it being prescribed by a neurologist. Like I said, the neurology guidelines from 2019, they don't specify which drugs should be used first line. The American Academy of Neurology guidance pretty much leaves it up to the provider. And they just talk about which drugs are more effective, and kind of like the background slide that I showed earlier. We know that Tisabri probably it's more likely to cause PML of all the MS drugs, but we don't have comparative studies that have looked at the harms. So does that answer your question, Stacy?
Yeah, I think so. So, I mean, what does everybody else think? I would tend to agree with Pat that, you know, if the neurologist is in the best position and these are going to be these are likely going to be lower utilization drugs, that if I would support removing number 4 unless the rest of the committee has strong objections to that.
I would add, as Linda mentioned, there is a REMS program for Tisabri.
Oh, yeah. Okay.
So that helps with the safety assessment.
Right. Yeah.
And
I would be definitely in favor of removing question 4.
Okay.
Deanna, this is Jeannie. Can you explain what you just said? There is a what assessment?
Oh, I'm
I don't know
sorry.
what that is.
Risk evaluation mitigation. So a REMS program is something that before a prescriber can prescribe it, they have to go through training through the REMS program.
Similar to Accutane, Jeannie.
Yeah, thank you.
Yeah, she's quite familiar with that one.
Yes, thank you.
Thank you. I should have specified what that is. I apologize for not being more clear.
No worries. I'm new. All good.
This is Eddie. I agree with removing 4. In my experience, my limited experience with MS treatment, I find that, you know, the neurologists that are selecting Tisabri early in disease course are, and you know, often because of the heterogeneity of the presentation, they are selecting those really specific patients based on that early disease progression, and so I would tend to defer to that expertise as well and not stand in the way of that.
Okay. Sounds like the group is in favor. Do we need we don't need a motion yet, correct?
I have another question. This is Jeannie. So just curious about, so if we did remove number 4, can you go back and look at utilization and one of our groups, and then look at the cases where it's being used to make sure that the intent of the removal has been followed?
We could certainly do that. And I will tell you, this is generally processed through medical claims. We did not have any medical claims for fee for service. I didn't see any claims in the CCO patients either. Most of our medical claims for these products were for Ocrevus. Ocrelizumab.
So I will make a motion to approve all of the committee of the of the staff's recommendations with the removal of 4 for Tysabri, question number 4, and the addition of the JC virus titer evaluation for Ocrevus.
For Tysabri.
No.
And Ocrevus, he also
Okay.
For Ocrevus.
Yeah.
For-
So he just rolled everything into one.
That is very impressive, Doug. Thank you. Do we have a second on that lovely motion?
Second.
Okay, all those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right, thank you.
Great job and good discussion. Thank you very much. And again, this just recaps what you were voting on, the 2 recommendations plus the 2 amendments that Doug outlined. So, and we will review this in executive session. Next, we have the testosterone for hypogonadism class update. If you're following the packet, it's on page 118, and we'll turn it over to Dave Engen.
All right, thank you, Roger. So good afternoon. Today we'll review androgens for the treatment of hypogonadism. We reviewed the literature for comparative efficacy and safety for the different androgen preparations, namely testosterone. Our focus was evidence for treatment for hypogonadism and not evidence for treating gender-affirming care, which was previously covered. In the review, we found 6 systematic reviews, 3 high-quality guidelines, and 2 FDA safety warnings, and we'll briefly share the highlights of the evidence in just a bit. So, male hypogonadism is defined by low testosterone production and low spermatogenesis. The condition may be congenital or acquired, and it's either from testicular failure or failure within the hypothalamic pituitary adrenal axis. Diagnosis of hypogonadism requires both decreased serum concentration of testosterone as well as negative health symptoms associated with that. So testosterone, it's approved as therapeutic agent, and it's FDA approved for symptomatic hypogonadism. But the long-term evidence of benefit and safety, for that matter, is unclear. Next slide, please. So for the systematic reviews, we focused on evidence for clinical outcomes that would be relevant to Medicaid. All were testosterone therapy versus placebo in this case. The first was by Cochrane. It looked at outcomes such as CV mortality and urinary prostate symptoms and those types of things. You can see on the chart there the different outcomes that were studied, and they found little to no difference in these outcomes versus placebo after treatment. Second systematic review is published by ACP. It looked at outcomes involving physical function, mental health, and different adverse effects. Overall, testosterone therapy, once again, very little to no difference in effects compared to placebo. And Hudson also reviewed testosterone therapy in a variety of males with hypogonadism and found slight differences in quality of life, different measures of those scales, but no difference in psychological outcomes compared to placebo. Moving on to the next slide. There were 3 systematic reviews that focus mainly on cardiovascular safety outcomes, so MI, stroke, VTE, DVT, etc. And once again, found no difference in risk compared to placebo. As far as the guidelines, there's some newer guidelines. The Endocrine Society gave some guidance on testosterone therapy. Essentially, they recommended not prescribing testosterone in males who are planning fertility or have a variety of health comorbidities that could be worsened by therapy, such as the different prostate conditions. I have them listed there for you, uncontrolled heart failure, prothrombotic conditions, and the like. Also, they recommend not routinely prescribing testosterone therapy to adults 65 and older with low serum concentrations. And then not to prescribe testosterone for the purpose of improving glycemic control in men with type 2 diabetes. Yeah, and a few more guidelines. ACP recommended against testosterone treatment for age-related low testosterone for purposes of energy boosting or for improving energy, vitality, physical function, or cognition. And the EAU, they made similar recommendations while promoting conventional medical therapies for conditions such as depression and osteoporosis rather than testosterone therapy. Few new testosterone formulations that have come out since the previous review. There were 4 general ones. One is an injectable and the other are oral. So Xiosted, Jotenzo, Tilando, and Kizotrex. So like I said, the first is an injectable agent. And the last 3 you'll see are oral capsules. They're all FDA approved as replacement therapies for males with testosterone deficiency. Each of the oral formulations have different strengths and they're not interchangeable. Variety of options there if needed. The next slide, there were some safety alerts of relevance. One, it's an older one, but wasn't presented yet. So it was a warning regarding all testosterone products for abuse potential, and that abuse increases risk of adverse effects is basically what that was saying. And the other safety alerts, it was emphasizing that topical testosterone preps are contraindicated in pregnant females due to virilization of the fetus. And it also warns about the potential for skin transfer from treated men. So it's delineated in more detail in the updated prescriber information. So lastly, there's just one minor change or update, I guess, to the PA criteria. So we could actually go ahead and skip to question 8 if you'd like. You'll see it here in red. We basically clarified the need for medically appropriate documentation when treating hypogonadism. Basically, to get approval, we're asking that the prescriber supplies supportive documentation for the condition. And if so, the patient can be approved for up to 12 months. Mainly, we added that red paragraph in the far left column. And then the other columns is just basically a clarification of the EPSDT review. So that was basically it for the changes in the PA criteria. So as far as the recommendations, there were no changes to the preferred drug list recommended based on evaluation of the clinical evidence. And we will evaluate comparative medication costs in the executive session. So if there's any questions from the P&T committee, I'll take those. Otherwise, turn it back to Roger.
Good job, Dave. Any questions for Dave? Hearing none, we do not have any public comment, so the recommendation is in front of you. No change to PDL based on the clinical evidence. Update the PA criteria as proposed to clarify the medically appropriate use. And we will be looking at pricing in executive session. Do we have a motion to approve? Or questions?
Motion?
Thank you, Pat.
This is Jeannie. I'll second.
Thank you, Jeannie.
All right, all those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right, thank you.
All right, we're cruising along. So next, draw your attention to the inflammatory bowel disease class update. That update starts on page 144 in the packet, and we'll turn it back over to Deanna.
Thank you, Roger. Yeah, we'll be looking at the oral and rectal formulations for inflammatory bowel disease. You may recall in our last P&T committee, we talked about the targeted immune modulators for Crohn's disease and ulcerative colitis, but we haven't reviewed the oral and rectal meds since 2015. So it's about 9 years of evidence. So this review evaluates all the evidence that's been published since then. In addition, we had 2 new budesonide products that were FDA approved that were originally put into this class because oral budesonide is used to treat Crohn's disease. So we'll be looking at the evidence for those 2 new products as well. Next slide, please. So just to summarize, the current PDL status is in Appendix 1, which is on page 177. So the oral preferred products that we have, or actually the preferred products we have are mesalamine capsules, tablets, enemas, and the suppositories. And then the other 5 acetylsalicylic acid or ASA products. So the oral forms of valsalazine, sulfasalazine, and olsalazine, those are all preferred, in addition to the prednisone and budesonide capsules. If any products are non-preferred in this class, they're just subject to the general PA criteria for non-preferred medications, which means we just look to make sure that it's being prescribed for an FDA-approved indication and that the condition is funded by the Health Evidence Review Commission, or HERC. In the second quarter, about 82% of our utilization of conventional therapy was for preferred products, and 18% was for non-preferred mesalamine capsules and tablets that are not currently preferred. Next slide, please. So since the last P&T review, there were 9 systematic reviews evaluating the conventional oral and rectal therapy for ulcerative colitis and Crohn's disease. I separated the reviews into ulcerative colitis and Crohn's disease because the treatments are different for each condition. So for the systematic reviews for UC, we had 2 Cochrane reviews in August of 2020 that basically were looking at the safety and efficacy of the oral 5-SA products. They lumped mesalamine, olsalazine, and valsalazine together and compared them versus sulfasalazine. And basically, they looked at either induction of remission in the first review or looking at maintenance of remission in UC in the second review. The first review showed that 5-SA products are not more effective than sulfasalazine for inducing remission. They looked at dosing, and they showed that once-a-day dosing of the 5-SA products seems to be as efficacious as the 2 to 3 times a dosing. And then they also looked at differences in safety and efficacy, and found really there was no difference between the various 5-ASA formulations. When looking at maintenance of remission, they showed that the 5-SA products were inferior compared to sulfasalazine for maintaining remission. There was no difference in adverse effects and no difference in dosing. Next slide, please. There was 3 additional systematic reviews by Cochrane looking at other therapies for UC, and these were all pretty much low quality evidence. So there was low quality evidence regarding the use of tacrolimus for inducing remission in steroid refractory UC. Low quality evidence regarding the use of the thiopurines for maintaining remission in UC, especially in patients that can't take mesalamine or sulfasalazine, or patients that needed steroids. And then there was no good evidence for the use of methotrexate in UC. Next slide. Switching gears into Crohn's disease. So we had a couple Cochrane reviews in 2019 that looked at, again, looking at the 5-ASA agents. These were patients that had surgically induced remission for Crohn's disease. And mostly they were looking at 5-SA compared to placebo. So it showed that the 5-SA preps were better than placebo for maintaining remission. Sulfasalazine wasn't as effective against placebo in maintaining remission. That was based on low and very low quality evidence. And then when they compared the 5-ASA agents to thiopurines, azathioprine or mercaptopurine, the evidence was unclear in terms of which one was better. And then in the other Cochrane review, they looked at maintenance of remission, and it looked like the thiopurines were better than the placebo. There was no difference in the number of relapses when the thiopurines were compared to 5-SA products, although they did see more side effects with the thiopurines, which is not surprising. Next slide, please. And then we had two more reviews. They looked at 5-SAs versus placebo or steroids or other aminosalicylates. And in Crohn's disease, sulfasalazine is not very good. It was not superior to placebo, and it was inferior to corticosteroids. And the same thing with olsalazine and mesalamine. They were not effective compared to placebo. And then the final Cochrane review looked at maintenance of remission. And again, there was no difference between placebo and 5-ASA products. Next slide, please. So now we'll move into guidelines, and a lot of these guidelines used those systematic reviews that I just outlined. So in 2022, the European Crohn's and Colitis Organization issued quite a number of recommendations. I just highlighted the recommendations that were considered strong recommendations, although it's interesting that they made strong recommendations, but most of these are based on low quality evidence. Basically what they're saying for for ulcerative colitis, to start with 5-ASA products at a dose of more than 2 grams per day. If they have distal UC, the rectal 5-SA is recommended. Rectal steroids are recommended if they have distal colitis. And then maintaining remission, again, the 5-ASA agents at a dose greater than 2 grams per day. If their patients are not if they're steroid dependent or if they cannot take the 5-ASA products, using thiopurines is recommended. And then oral prednisolone is also recommended to induce remission in patients with moderate to severe active ulcerative colitis. Next slide, please. The 2019 American Gastrological Association, they only had one recommendation that was strong. The other recommendations are listed in the packet on table 3 on page 164. But basically what they were saying is to manage mild to moderate UC, to use standard dose mesalamine or the two diazo bonded 5-ASA products, balsalicide or olasalazine, over low dose mesalamine or sulfasalazine or no treatment to induce and maintain remission in patients with mild to moderate UC. And this was based on moderate quality evidence. Next slide, please. Switching to Crohn's disease, the 2019 European organization came out with some recommendations. Again, these are the strong recommendations and a little bit higher quality evidence, moderate quality evidence for budesonide for induction of remission in patients with mild to moderate CD. The ASA products are not recommended in Crohn's disease, and then thiopurines are recommended in patients that are steroid dependent. Next slide, please. The American Gastrological Association came out with some guidance for management of moderate to severe Crohn's disease in 2021. And here's where we start to see the TNF antagonist emerge. I didn't focus on a lot of this evidence because we reviewed it when we talked about the targeted immune modulators, but for moderate to severe CD, they're really recommending to start with the TNF antagonists. And in 2021, these were the 3 products that had FDA approval for Crohn's disease. You may recall we have quite a few more products now that are approved for CD and UC. And then they do not recommend using steroids for maintenance of remission in CD. And then they also recommend against using 5-ASA or sulfasalazine. So basically, this guidance is in our targeted immune modulator recommendations in terms of what people should try and fail before they move to a TNF antagonist if they have mild to moderate, either CD or UC. Next slide, please. I did find some pediatric guidance, which was helpful. There are very few studies in children with pediatric Crohn's disease, so most of the evidence for those recommendations was very low quality, and they extrapolated a lot of the guidance from adult studies. And so for CD in kids, they recommend corticosteroid, including prednisone, but in children, you have to be careful when you're using steroids because it might impact their growth and bone development. They do not recommend oral 5-ASA products, and thiopurines are also not recommended, mostly because they're not approved for use in pediatric patients. Next slide, please. There were some new indications. So the budesonide capsules have an expanded indication to use in Crohn's disease in children that are 8 years and older. And then the mesalamine delayed release tablets also have expanded indication to use in pediatric patients that weigh at least 24 kilos. Next slide. So the new formulations, the information about the two diseases or the two conditions that these two budesonide products are approved for is covered extensively in the background. The targeted release budesonide or Tarpeo, this is the very first FDA-approved agent for use in adults that have nephropathy. It was initially approved in 2021 just to reduce proteinuria, and then in 2023, the initial indication was expanded to include reducing the loss of kidney function in adults with primary IgA nephropathy who are at risk for disease progression. The second product, the budesonide oral suspension, this is the second FDA-approved agent for use in eosinophilic esophagitis. And you may remember we reviewed dupilumab way back in October 2022 because dupilumab was the first FDA-approved product approved for eosinophilic esophagitis. The PA criteria for dupilumab are presented in Appendix 3 on page 179. But basically, the current recommendations for treatment of eosinophilic esophagitis are to start with the off-label use of proton pump inhibitors. And if that doesn't help resolve the symptoms, there's also some evidence for the off-label use of locally applied corticosteroid preparations, in particular using fluticaside, the nasal fluticaside, and letting that go down the back of the throat into the esophagus to help alleviate those symptoms. So we'll go into the recommendations on the next slide. So based on the review of the evidence, we don't have any recommendations for the PDL for the drug class of oral and rectal agents for inflammatory bowel disease. We would like to make the budesonide 4 milligram delayed release capsules, the Tarpeo, non-preferred, just to make sure that we have appropriate utilization in patients that have the IgA nephropathy. And then we'd also like to recategorize that product to be in the oral glucocorticoid drug class on the PDL. This would be non-preferred with the general PA criteria, so we would just make sure that they were using it for the approved FDA indication, which is funded by HERC. For the second budesonide product, the oral suspension, we'd like to make that non-preferred with PA criteria, and we would like to use PA criteria that is similar to what we've developed for dupilumab for the eosinophilic esophagitis. we couldn't put the budesonide in the same drug class because the PA criteria for dupilumab in eosinophilic esophagitis is in the target immune modulators for asthma and atopic dermatitis, because those were the first two indications for dupilumab. And then we would like to recategorize the glucocorticoid oral class for the budesonide oral suspension. And then we'd also like to look at costs and exec session. I want to just show you the PA criteria on the next slide. They're very short for the budesonide oral suspension. We just want to make sure that it's being used for the FDA-approved age and indication. And right now it's approved for, what did I say? Kids 11 years and older for 12 weeks of treatment for the eosinophilic esophagitis. And we do want to make sure that they've tried the PPI therapy for at least 8 weeks and the corticosteroid therapy before they progress to the budesonide oral suspension. Again, that's only approved for 12 weeks. So with that, I would like to open it to the P&T committee to see if they have any questions.
Good job, Deanna. We do not have any public comments, so questions from the committee for Deanna.
I'll just chime in to say the age cutoff, I'm guessing that's both the label and maybe a trial inclusion criteria. Like I use a lot of budesonide in younger kids. And so we were always extrapolating, but I think as long as there's a pathway through medical review to appeal, I don't feel too strong, but feel obligated to acknowledge that.
This is just for the oral suspension. Do you use a lot of the oral suspension in kids because it's easier for them to swallow?
Yeah, exactly.
Okay. That totally makes sense. Yeah, and I think, if it's off label, we would totally look at it. Yeah, because this is the first FDA oral suspension product that's been approved.
But I guess we compound it. But yeah, I think as long as we've got a pathway, it's
Yeah, I think
totally
there are
right.
compounded, there's an ability to compound it, yeah.
Pediatric gastroenterologists basically use the MDIs, budesonide NDIs, and have them, swallow it. Yeah.
Yeah.
We've been approving that for all of their requests below age 12.
That's helpful to know. Yeah, Dr. Origer was the one that suggested we use the nasal. I think he maybe saw that a lot in his practice.
Other questions or discussion?
Well, I'll go ahead and move for approval as recommended.
Appreciate it, Doug.
Do we have a second?
I'll second.
Thank you, Tim.
Thank you. All right, all those in favor?
Aye.
Aye. Aye.
Anyone opposed? Abstain? All right, thank you.
Well, we're cruising right along. We had scheduled a break. I think I'm still going to take the break at this time, just because we have some people that are wishing to provide public comment that might have stepped away, and I want to get closer to the scheduled time to do that. So with that, I am going to share my screen. And with that, we'll see you back here in 15 minutes. All right. I hope everybody had sufficient time to take the break they needed. We are going to continue on. We have 2 subjects left and then executive session. The next subject up for review starts on page 189 in the packet of materials. And going to turn it over to Sarah Serwood for the Duchenne Muscular Dystrophy class update.
Thank you. So the purpose of this update is to evaluate evidence for a new drug that was recently approved by the FDA called Givinostat, and then take a look at new evidence that's been published since we last reviewed this class. We did look at evidence for this class not too long ago in February of 2024, so it's been about 6 months. Just as a reminder, Duchenne's muscular dystrophy is a rare X-linked genetic disorder, so it primarily affects young boys. That's caused by an absence of a functional dystrophin protein. Patients who have Duchenne's muscular dystrophy have progressive muscle deterioration, which eventually leads to loss of ambulation and decreased muscle strength. There is no curative treatment for Duchenne's muscular dystrophy. The current guidelines and treatments focus on improving symptoms, enhancing quality of life, and decreasing disease progression. According to the American Academy of Neurology, corticosteroids are recommended as a first-line treatment because they have shown for ambulatory children to delay loss of motor function decline, loss of ambulation, help preserve pulmonary function, and reduce the risk of scoliosis. There are several targeted therapies for Duchenne's muscular dystrophy that are on the market that PNT has reviewed previously. Most of them have been approved through the accelerated approval pathway and are awaiting confirmatory trials. But we'll get into some of the evidence for these newer therapies just a little bit. In this literature search, we didn't identify any direct comparative evidence for the targeted therapies in people with Duchenne's muscular dystrophy. But in this review, there is evidence evaluating the gene therapy, delandistrogene moxeparvovec, which received an expanded indication for non-ambulatory people with Duchenne's muscular dystrophy and ambulatory people over 5 years of age who have DMD. And this was previously approved through the accelerated approval pathway in people who are ambulatory who are only 4 to 5 years of age. And so that indication for that drug has been expanded. And then the new drug, Givinostat, is a histone deacetylase inhibitor that's approved for people with DMD. This drug is the first histone deacetylase inhibitor that has an indication for DMD. There are other histone deacetylase inhibitors with other indications, like, for example, they are indicated for multiple myeloma. But the mechanism in DMD, Givinostat is thought to upregulate follistatin, and then which helps increase muscle generation. And this reduces the fraction of healthy muscle cells that are replaced with fatty or fibrous tissue in people with Duchenne's. So first, taking a look at the expanded indication for the gene therapy. This was a confirmatory phase 3 trial for delandistrogene moxeparvovec. It was double-blind, placebo-controlled, included 125 people. At the time this review was put together, this was an unpublished trial, so we couldn't do a full quality assessment for this study. People who were included in the study were an average 6 years old, had a mean time to climb 4 stairs of 3.2 seconds, an NSAA score of 23. They did have to be ambulatory and 4 to 7 years of age and on baseline corticosteroids in order to be enrolled. They were excluded if they had heart failure with a left ventricular ejection fraction less than 40%. They looked at outcomes at 52 weeks in comparing treatment to placebo. The primary outcome was a change in the NSAA score, which evaluates a variety of functional assessments for members, primarily looking at motor function. The mean difference between the two treatments was 0.65 points on this scale, which was not statistically significant between groups. People randomized to treatment had an improvement of about 2.5 points, and people randomized to placebo had an improvement of about 1.9 points. The secondary outcomes, they looked at a variety of other pre-specified motor function outcomes, including the number of NSAA items that improved for each person, the stride velocity 95th centile, which is an ambulatory assessment that's assessed using a wearable device that's intended to measure the peak ambulatory ability of the patient by identifying the velocity of the top 5% most rapid strides that the person takes in a real-world setting. They looked at the PROMIS score, which evaluates upper extremity function, the time to rise from the floor, time to ascend 4 steps, and 2 different measures of ambulatory assessment, the time it takes to walk or run 10 meters and 100 meters. They reported outcomes for 4 of these assessments, didn't report outcomes for 2 of them. 3 of the reported outcomes did show a difference from placebo, although differences are small and it's hard to tell whether these differences are clinically significant. In most cases, the clinical significance might depend on the baseline functional ability, and there's not a lot in the literature that's describes what a clinically relevant change in these outcomes is. One of the outcomes that was reported as a secondary outcome wasn't statistically significant from placebo, and that was the 100-meter run walk time. Looking at the safety that was reported in this unpublished trial, common adverse events were very similar to the original study that was used for accelerated approval, and these included vomiting, decreased appetite, and increases in glutamate dehydrogenase. Serious adverse events were more common with treatment compared to placebo, with 22% of people in the treatment arm experiencing a serious adverse event compared to 8% with placebo. And these included myocarditis, hepatobiliary disorders, including liver injury, nausea and vomiting, and rhabdomyolysis. Acute liver injury was also more common with treatment at 41% compared to 8% with placebo. And these were primarily mild or moderate symptoms that did resolve with an increase in the corticosteroid dose. And liver injury is something that is a trend with quite a few of the gene therapies. And just a note, the drug did receive an approval in a non-ambulatory population, but our data for non-ambulatory patients is extremely limited and it included only 8 patients. So as far as evidence limitations, there are now 2 randomized controlled trials, one that's published, one that's unpublished, in patients treated with delandistrogene moxeparvovec, which have shown no difference in their primary outcomes of global motor function compared to placebo after 48 and 52 weeks. The confirmatory trial that's described here is unpublished, so that limits our ability to do a full risk of bias and quality assessment. Not all of the secondary outcomes were reported in this study, and the lack of a pre-specified analysis plan to control for type 1 error increases the risk of false positive results with those secondary outcomes that were reported. There is insufficient data looking at subgroup analyses in these studies to identify which patients are most likely to have benefit from treatment. And we don't have any evidence that's evaluating other outcomes other than motor function. There's cardiac outcomes and lung function outcomes haven't been studied for this drug. Serious adverse events were more common in people treated with delandestravine, moxaparvovec, and safety in a broader population of people with more severe or progressive disease is really unknown at this point. And then shifting focus to look at Givinostat, it was approved primarily based on one phase 3 double-blind placebo-controlled trial. Looked at Givinostat with weight-based dosing compared to placebo, and included a little over 100 patients in this trial. The average age of people in the trial was about 10 years. They had a 4-stair climb at baseline of a little over 3 seconds, and time since diagnosis was about 5 years. They did have to be ambulatory to be included in this study and on corticosteroids for more than 6 months. There were some pretty extensive inclusion criteria as far as excluding people with comorbid conditions and only including people who had functional assessments within a certain range. So they had to have a time to rise of 3 to 10 seconds and time to climb 4 stairs of less than 8 seconds. The primary analysis also limited the population to people who had a vastus lateralis fat fraction between 5% and 30%. People that were in the trial that didn't have this were still allowed to participate, and they were included in a different population, but they weren't analyzed with the primary analysis. And this inclusion criteria was intended to identify people who were at risk of motor function decline, but were not at risk for sudden loss of ambulation. So trying to identify those people that might have disease progression, but wouldn't immediately lose the ability to walk. They looked at outcomes at 72 weeks, and their primary outcome was the time to climb 4 stairs. And with Givinostat, people randomized to Givinostat had an average improvement in that outcome of 1.25 seconds compared to placebo, and the time to climb 4 stairs lengthened by 3 seconds. They did do 2 different analyses with when they were comparing these data. The first was a pre-specified analysis using a single value average for missing data. And with that analysis, they showed the difference was about, between the groups, was about 1.78 seconds, and showed a statistically significant difference between the groups with that type of analysis. However, the FDA did recommend a different analysis for missing data using mixed model repeated measures, which accounts for all of the outcomes that are observed. And when the FDA reanalyzed the data using the MMRM for the missing data, they had a similar point estimate, so a difference between groups of about 1.6 seconds, but the difference between treatment and placebo was no longer statistically significant. Secondary outcomes, they looked at NSAA score, time to rise, 6-minute walking test, and then knee extension strength and elbow flexion strength. And these outcomes were not statistically significant from placebo based on the pre-specified statistical analysis plan. So common adverse events that were observed in this study were primarily gastrointestinal. Diarrhea, abdominal pain, nausea, and vomiting were common. Blood disorders were also observed, primarily thrombocytopenia in the clinical trial, and some patients did have hematoma as well. Hypertriglyceridemia was common, and then rash, arthralgia, fatigue, and dizziness were more common with treatment compared to placebo. An interim safety, they did make modifications after an interim safety analysis. They reduced the starting dose based on the incidence of adverse effects. About 42% of people randomized to treatment had dose modifications due to side effects compared to 8% of people randomized to placebo with a number needed to harm of 3. Most people didn't discontinue treatment because of those adverse events, only 3% with treatment, and no patients in the placebo group actually discontinued treatment because of those side effects. Other warnings and precautions that are included in the labeling include QT prolongation and myelosuppression, which are common with the other histone deacetylase inhibitors that are on the market. And safety in people with more advanced disease or people who have heart conditions is unknown because those people weren't studied in this trial. It was a relatively small study, and so there were some imbalances in baseline characteristics between groups. There was high risk for attrition bias related to that missing data, and then also high risk for performance bias related to potential unblinding because of the adverse events observed in the trial. The trial data is most applicable to people who are ambulatory on corticosteroids. They targeted people at risk for motor function decline, but who were not at risk for that sudden loss of ambulation. And so data for other populations is pretty limited. People who identified as non-white were underrepresented in the study. About 91% of people identified as white in the study. There are no data that are evaluating combination use of targeted treatments for Duchenne's muscular dystrophy. This is a new mechanism of action, so theoretically, you could maybe use it with some of the other targeted therapies, but we don't have any data evaluating combination use of treatments. And we don't have any data that show that this drug impacts lung or cardiac functional outcomes. So the recommendations are to update prior authorization criteria to incorporate the expanded indication for delandistrogene moxeparvovec because it is FDA approved, and for the new drug givinostat. We don't have any recommendations for PDL changes based on this new evidence, but we will be looking at cost in executive session. I'll go through some of the PA changes momentarily. Any questions on the evidence before I get to the PA recommendations? All right, hearing none. So these changes are for delandistrogene moxeparvovec. We do already have PA criteria in place for this drug. And so the criteria essentially confirms that it's, that they do have the diagnosis and that they're seeing a specialist for the condition. In question 4, we're updating the question to align with the FDA approved ages. So it's now approved in over 5 years old. We are taking out the question that previously asked about ambulatory ability, since it now is approved in people who are non-ambulatory. And so you'll see that removal in question 5 there. And then the other change is adding question number 10. I thought this might be appropriate just because we have very limited evidence that this drug improves motor function, and we do have evidence that it has more serious adverse events compared to placebo. And so just requiring documentation that the provider and member have discussed the potential risks of treatment and made sure that the member is informed before they start treatment. And then for changes related to givinostat, we've consolidated questions from that were previously outlined in our questions and consolidated those safety questions into the table at the start of the criteria. And so you'll see we've removed a question related to baseline renal function and moved that into the table, and then added the recommended monitoring for triglycerides, platelet counts, and ECG in appropriate people for Givinostat. And so that's outlined here. And then other questions that are related to Givinostat in the criteria, we've included a question to document that they're using a minimum effective dose that's recommended in the FDA labeling, just because there are the adverse effects related to this treatment were significant in the clinical trial, and the FDA outlines what to do in those circumstances with dose reduction, but they do recommend discontinuing the drug if you've reduced the dose twice and is still unable to tolerate it. So making sure they're using that minimum dose that's recommended in the FDA labeling. And then question 11 is modified slightly just because there's no data to evaluate combination use of treatments for Duchenne's muscular dystrophy. So requests for 2 or more targeted therapies, we're recommending it be denied in that question if a patient's on more than one treatment. I think that's everything. Happy to take questions if you have them.
Nice job, Sarah. Questions on the evidence or on the recommendations?
For the second drug, PA line 13, with the needing 6 months of steroids, do we think that was just sort of clinical trial inclusion criteria and maybe not like truly reflecting like appropriate use? And that like the steroids aren't going to be disease modifying and
Well, steroids are recommended as a first-line treatment in Duchenne's muscular dystrophy. And so I think it's appropriate for people to be on them before they try any of these other disease-modifying therapies. There is evidence that steroids actually improve risk for scoliosis and lung function.
that sounds good.
Other questions? We do have some public comment, and obviously we'll let you entertain questions of both the public commenters and Sarah before we move forward. But I'll give it one more second to see if you have any for Sarah on what's been presented thus far. Okay, hearing none. I have Brian Denger. He's with the Parent Project Muscular Dystrophy. Brian, are you able to unmute your line?
Yes, I have.
Excellent. Glad that you're back with us. I'm going to share my timer. And with that, there we go. You submitted some written testimony. I put that out on our website for the committee's review. And also, you're allotted up to 3 minutes now. So the floor is yours.
So I want to first thank the committee for the consideration of these therapies. My name is Brian Denger. I'm with Parent Project Muscular Dystrophy. It is the largest volunteer health organization focused on Duchenne and Becker muscular dystrophies, and I'm involved in community engagement, which is the reason for my testimony. I want to add a little bit of context. First, thank you to the committee for the potential new criteria for these 2 treatments. I'll use the brand names because it's easier for me: Elevidys and Duvizat. Duchenne is a relentless, rapidly progressing muscle wasting condition, and what is considered modest benefit can translate into cumulative positive benefit for patients. As an example, it was mentioned that the first line of therapy for Duchenne are glucocorticoids. And also mentioned was the fact that patients who are on long-term steroid therapy can see a reduced need for spinal surgery as a consequence of scoliosis because of preservation of trunk strength with longer periods of ambulation. Walking is typically extended by 2 to 3 years. And this drug also, like these others that are being considered today, comes with a huge laundry list of potential negative serious side effects. What I'd like to say in particular is that in allowing patients and families to make decisions about the treatments that they pursue is a value judgment that is basically best reserved for the patient and an expert clinical team. The prior authorization question in question 10 about ensuring that a risk benefit analysis has been made with patients considering Elevidys is appropriate. I think that families need to be very mindful that these therapies, while they have the potential to provide some benefit for preservation of function and ambulation, should not be hyper focused as the only function preserved. The families need to also be concerned about the potential side effects. So in closing, thank you very much to the committee for considering these prior authorization criteria and potentially making these therapies available to those who are covered by Medicaid in Oregon. Thank you.
Thank you for your comments, Brian, and for taking the time to be here. Both your advocacy and taking the time to engage our committee today. So does the committee have any questions for Brian? All right, again, thank you, appreciate it. Next, we have Armin Kachatourian, representative from Sarepta Therapeutics, manufacturer of Elevidys. Armin, are you able to unmute your line?
I am, Roger. Can you hear me?
Hear you loud and clear.
Excellent. Thank you very much. Thank you. Greetings, everybody. Armin Kachatourian with Sarepta Therapeutics. I just want to give my thanks to the committee for reviewing Elevidys and generating a policy in alignment with the FDA label. In light of that policy and alignment with the label, I'd like to yield back my time to the committee, unless there are any additional outstanding questions I can address in the meantime.
Always appreciated when you're respectful of the committee's time and appreciative of the work that we're putting forward. Does the committee members, do you have any questions for Sarepta Therapeutics in regards to Elevidys? All right. Again, thank you, Armin. And we also have Dr. Erica Finanger. She's known to the committee because she is expert at OHSU. For those that were previously on the committee, you may remember she was appointed as an ad hoc expert back in February to participate in the conversations. While not appointed this time, appreciate her willingness to show up to provide public comments. She is, again, at OHSU on her disclosures. You know, she wasn't asked to be here, but she has participated in research and doing both advisory boards and some of the clinical trials. Dr. Finanger, are you, I hope I got it right the last time, Finanger. I hope you are able to unmute your line.
Yes, can you hear me?
Hear you loud and clear. I don't know if I missed anything with my introduction. If you want to share anything with the committee.
No, just thank you for allowing me to be here. You did do an excellent job with my last name. I'm Dr. Finanger, pediatric neuromuscular physician at OHSU. And just to clarify my disclosures to make sure that I'm clear, I have performed the clinical trials both for the gene therapy product we're discussing today, as well. We participated in the Givinostat study. So I would just like to thank you again for your review. I think it was excellent. I do reiterate what Brian shared earlier, that clinical trials are only so good at measuring outcomes. And I do think there are, I appreciate you looking at the totality of the evidence because of the meaningful changes that can happen. And that's somewhat difficult to capture in a one-year study in a disease that is very heterogeneous. So I have really no comments about the delandistrogene approval criteria, but did have a bit of a question just trying to understand what I guess criteria number for Givinostat, the criteria that talks about disease modifying, what exactly is included in that? Is that intended just to be for the exon skipping drugs, or is that also including Givinostat? And then I guess my last comment is just with regards to the steroids, as was discussed by one of the board members. Some patients, unfortunately, though they are standard of care, are unable to tolerate, and we do just about everything we can to keep kids on corticosteroids, because as you mentioned, we have the longest and best evidence for that. But I just want to be, families cannot tolerate that. And so I would hate for them to be excluded from alternative therapy simply because they were unable to tolerate the first line standard of care. So that is the extent of my comments, but happy to answer questions if that's appropriate.
You bet. So I appreciate those comments. I think you did have a question about question number 4. I think that we're going to be bringing this back up. Leave it to the committee now. First of all, any questions from you directly to Dr. Fanonger? Sarah's bringing up the criteria.
Yeah, and I'm not sure if I got your first question, but I'll try and answer it, and you can tell me if I'm on, if it's answered. So it sounds like you're asking whether Javinostat would be lumped in with the exon skipping therapies, and that was the intent with the policy, is to put them under the same criteria. And so the questions in the criteria do kind of delineate each. So there's questions specific to Javinostat, but they are all under the same criteria. Is that what you were asking?
I get my question was specifically with regards to criteria number 11 and whether or not combination therapy would be Javinostat plus exon skipping. Because as you talked about, they are have entirely different mechanisms of action.
Yeah, that is the intent. Yeah. So since they haven't been studied together, the request for 2 or more targeted therapies, I think, would be denied in that question as the criteria is written.
Question or feedback on that? I don't know if you're aware of studies being performed in that space or any anticipated literature that might be support.
If you're asking me, there is not ongoing studies right now. As you can imagine, both of these or all of these drugs, when you're enrolled in a clinical trial, you cannot be on any other non-approved therapy. And given how fast this therapeutic landscape has evolved, that has not yet been performed. I think there will be and are sort of real world phase 4 studies ongoing, but I imagine that data will be long time incoming. I guess my only other comment is, and that I don't know because I do not sit on this committee, if for other disease states, if if it requires a study of combination therapy in order to be instituted or is exclusively denied.
Yeah, it's not uncommon for many of our criteria to not allow combination therapy that hasn't been studied to be approved. I also open up to the committee if you have thoughts or questions about that, the comments and observations from Dr. Fanonger, or questions about this question number 11.
No, I would just echo your point, Roger, that I think there's certainly like precedent for us to not allow combination treatment in a setting like this.
And then the final point you made about the corticosteroids, I think we also address that by it's either used for 6 months or there's a documented contraindication. So trying to allow that pathway should those not be tolerated and not to have it be a full stop right there. All right. Thank you again for taking the time to join us, Dr. Fanonger. And the committee, any final questions for them, or we'll turn it back to Sarah to outline the recommendations and see if you have any questions about the clinical information she presented. All right.
Good.
So again, the recommendations from the committee are to update the PA criteria to incorporate the expanded indication for names that I will not try to pronounce. And no PDL changes are recommended based on the comparative evidence, but we will review costs in executive session.
We have a motion.
A motion.
Thank you, Pat.
I will second the motion.
Tim.
Appreciate it, Tim.
All right. All those in favor?
Aye.
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 Anyone opposed? Abstain? All right. Thank you.
Great. Appreciate it. Our final class review of the day starts on page 214, again, if you're following in the packet. And I'm going to turn over the class update to, I believe, Kathy Santana to lead us off.
Yeah, thanks, Roger. So today we'll be looking at the H. pylori class and evaluate the new evidence for treatment as well as a new drug. The new drug evaluation pertains to the new potassium competitive acid blocker, which we'll just refer to as PCABs, vonoprazan, or brand name Voquenza. And I'll present the evidence related to the treatment of H. pylori, and then Deanna will be presenting the evidence for vonoprazan for the use in erosive esophagitis and non-erosive GERD. In addition, there's new evidence from one systematic review and meta-analysis, 5 new FDA safety alerts, and then of course we'll be talking about the new drug. Last quarter, there were actually no claims for the H. pylori regimens. Just a little background, we currently have 5 combinations approved for the treatment of H. pylori. The first one is a bismuth metronidazole tetracycline combination that's used with a proton pump inhibitor for up to 10 days. The second is lansoprazole, amoxicillin, and clarithromycin. The third being omeprazole, amoxicillin, and rifabutin. And then number 4 and 5 are 2 different combinations of the new agent, vonoprazan with amoxicillin, and then vonoprazan with amoxicillin and clarithromycin. So historically, the treatment of H. pylori has been with a PPI or bismuth and PPI, and then 2 antibiotics. First-line treatment regimens often include clarithromycin or amoxicillin. However, resistance has caused eradication rates to drop to less than 80%, primarily thought to be due to the clarithromycin, metronidazole, and levofloxacin resistance. Recently, the U.S. reported around a 4 to 16% resistance rate to clarithromycin when used for primary treatment. Now, I do want to add that this comes from guidance from 2017. However, just recently, there's updated guidance that came from the American College of Gastroenterology that was published last month, which missed our inclusion deadline and therefore is not critically evaluated and included in this review. But I just want to mention a couple highlights of what they reported on. And they mentioned that due to rising resistance rates and then the new evidence on rifabutin and the PCABs, they have updated their recommendations to include bismuth quadruple therapy for treatment-naive and treatment-experienced patients as a first-line treatment option, as well as utilizing regimens with rifabutin and PCABs. Additionally, we do have dose limits on this class in place for H. pylori that allows for up to 2 weeks of treatment, and non-preferred products do go through a general non-preferred product PA criteria. Preferred H. pylori treatments in this class are the bismuth metronidazole clarithromycin combination and the lansoprazole amoxicillin and clarithromycin combination pack. So as I mentioned, we just had one systematic review, and that came from CADITH, and they looked at different durations of treatment for H. pylori. They compared a 7-day treatment to the 8 to 14 days of treatment. The antibiotics evaluated in this review included amoxicillin, clarithromycin, levofloxacin, moxifloxacin, and tetracycline. And not surprisingly, they did find higher eradication rates with the longer treatments of 10 to 14 days compared to 7. And that is what current guidelines currently recommend as well. So there are several safety warnings for this class. However, they only pertain to 2 different treatments. The first 2 relate to the bismuth metronidazole tetracycline combination product, Pylera. And this is actually due to the metronidazole component for both of the warnings. The first one is the contraindication for use in patients with Cockayne syndrome, which is a rare fatal autosomal recessive neurodegenerative disorder, and that actually has been shown to cause hepatotoxicity and acute liver failure with fatal outcomes being reported. The second warning is with QT prolongation that has also been reported with metronidazole. The next three warnings relate to omeprazole, amoxicillin, and rifabutin, brand name Telesia. And these pertain to the risk of scars or severe cutaneous adverse reactions, which include drug reaction with eosinophilia and systemic symptoms, Stevens-Johnson syndrome, toxic epidermal necrolysis, and acute generalized erythematous pustulosis. So a lot of skin issues and reactions there. And then lastly, there's been post-marketing reports of erectile dysfunction. So moving on to the new drug review for vonoprazan. This product was approved by the FDA in May of 2022 and is indicated for the use in combination with amoxicillin or clarithromycin for the treatment of H. pylori in adult patients. It's available in two different types of combination packs, the dual pack, in which it's vonoprazan 20 milligrams taken with amoxicillin, a total dose of 1,000 milligrams for 14 days. And then the triple pack, which includes the vonoprazan 20 milligrams, again with amoxicillin 1,000 milligrams and clarithromycin 5 milligrams, this taken just twice a day for 14 days. As I mentioned, these are called, or vonoprazan is called a PCAB, and what this medication does is it increases gastric pH, allowing for maximal effect of antibiotics. And we have just one trial in which the FDA approval was based on. This product's actually approved in many other countries, so there are quite a few trials out there. But because of the high variability and resistant rates among antibiotics used in different geographical areas, these other trials aren't going to be presented at this time. So we'll just focus on the one that was done in the United States. So this was a non-inferiority trial that looked at the two different dosing regimens for vonoprazan. The dual regimen, so just the vonoprazan and amoxicillin, was actually open label. And then the triple therapy was double-blinded. There are 992 participants, around 51 years old, and predominantly female, with also an indication of dyspepsia. All patients had to have a confirmed H. pylori diagnosis by breath and biopsy, and as well as they did susceptibility testing. They also had to have at least one of the following: dyspepsia, a recent or new diagnosis, a non-bleeding peptic ulcer, or a peptic ulcer not previously treated for H. pylori, or the need for long-term NSAID therapy at a stable dose. The duration of treatment was 14 days, but the outcomes were assessed at 6 weeks, and it was non-inferiority and eradication rates in patients without clarithromycin or amoxicillin-resistant strains. And both combination regimens were found to be non-inferior to the lansoprazole combination treatment. They also looked at a secondary endpoint that looked at superiority and eradication rates in patients with clarithromycin-resistant infections, and both the vonoprazan combination products were superior to lansoprazole for that outcome. Trial limitations: a small percentage of the patients with comorbid peptid ulcer disease were actually enrolled in the trial, which is a real common risk factor for the comparison of vonoprazan dual therapy was open label, which leads to a high risk of performance bias, potentially. The study of vonoprazan also relied on the full analysis set population for the primary endpoint analysis. And for non-inferiority studies, they actually recommend the per protocol population, as it more accurately detects treatment differences. There was high attrition in both groups with no information on how the missing data was handled. And then, of course, we just have this one small study in the US to use for our evidence. Looking at common adverse effects: diarrhea, dysusia, vulvovaginal candidiasis, abdominal pain and headache, hypertension, nasopharyngitis. So fairly common adverse events there. Severe adverse reactions were rare in all treatment groups, but again, this is a real short-term study. Severe cutaneous reaction, C. diff, diarrhea and QD prolongation, as well as hepatotoxicity are also the potential risk of therapy with vonoprazan. And then adverse effects leading to discontinuation, to treatment discontinuations were actually higher in the triple therapy group at 2.3% compared to the lansoprazole group at 1.2%. So recommendations for the class is no changes to the PDL are recommended, and maintain the vonoprazan dual therapy and triple therapy combinations as non-preferred for the treatment of H. pylori. Vonoprazan monotherapy will require a PA and will be presented by Deanna following this presentation to give you more information on that, and then to evaluate costs in executive session. Are there any questions?
Nice job, Kathy.
Thank you.
Questions for Kathy on the information she presented? Okay. We'll turn it over to Deanna. I think we're on page 226 in the packet, if I'm correct, right, Deanna?
Yep, that sounds right. All right, so like Kathy said, we're going to just talk about PPIs and H2RAs, or histamine 2 receptor antagonists for erosive esophagitis. So if we could go to the next slide. So I looked at the evidence for the use of PPIs and H2RAs in a variety of conditions, and then mostly focused on the safety and efficacy of vonoprazan, the new potassium competitive acid blocker for erosive esophagitis. Next slide. So I found two systematic reviews. Both were, they were both done in pediatrics, but the first one focused primarily on management of GERD in infants and children, and it was very, very low certainty evidence, and it showed that omeprazole and ranitidine are probably similar in the impact they have on the reflux score. And then they also looked at two different studies that compared pantoprazole and rapoprazole in children that were over 1 year and older, and it found that PPIs didn't provide a whole lot of symptomatic or endoscopic benefit in children. So the authors pretty much concluded that more studies of these medications in pediatric patients with longer follow-up are needed, because these are pretty short-term studies. There is some thoughts that acid reflux can trigger asthma. So that's what prompted the 2021 systematic review to see if GERD treatment improved asthma in adults and children. And they could not find any evidence that that was the case. They only had two studies that had pediatric patients, so the evidence in children was pretty inconclusive, and when they looked at adults, it was all based on low certainty evidence. Next slide, please. In terms of guidelines, the American College of Gastroenterology did issue some guidance in 2022 and reiterated that an 8-week trial of using a PPI once a day to empirically treat GERD was appropriate. And they do prefer PPIs over H2RAs for healing erosive esophagitis, and also to maintain that healing. And those were strong recommendations based on moderate to high quality evidence. Next slide, please. In terms of new indications and safety warnings, there's a table on page 233 that has a lot more detail about the PPI safety warnings, but the labeling for dexlansoprazole was updated to reflect the risk of heart valve thickening in pediatric patients less than 2 years of age. The labeling for all the PPIs was updated to include the risk for nephritis, as well as severe cutaneous adverse reactions. And of course, if either of those effects occur, then the PPI therapy should be stopped. And then also there's been more reports of hypomagnesemia with prolonged PPI treatment. So next slide, please. Moving into the evidence for vonoprazan. So it does block the potassium exchange channel of the hydrogen potassium ATPase pump, which ultimately inhibits gastric acid secretion. So the FDA-approved indication initially was to heal all grades of erosive esophagitis and relieve heartburn that's associated with erosive esophagitis, just in adults. And the approved dosing is 20 milligrams once a day over 8 weeks to heal the erosive esophagitis, and then up to 24 weeks of the lower dose, 10 milligrams once a day, to maintain the healing of the erosive esophagitis. And then in July, they got an expanded indication to relieve heartburn associated with non-erosive GERD. That's called NERD. They just replaced the G with the N at a dose of 10 milligrams once a day, daily for 4 weeks. And we put this together because we were going to review this at our last meeting, but we ran out of time. I did review the evidence for the new indication in the packet if you wanted to take a look at that. But on the next slide, I'm just mostly going to talk about the evidence for healing of erosive esophagitis and then maintenance of healing. So this was, there was 2 parallel studies that were done. They were phase 3 randomized controlled trials. They were double-blind, non-inferiority trials. The first one, they compared vonoprazan 20 milligrams. The first phase, they looked at vonoprazan 20 milligrams once a day versus lansoprazole 30 milligrams once a day. And then in the second phase, the 24 weeks, I apologize. I said there was 2 randomized control trials. It was just one, just this one. But in the second phase, they looked at the lower dose of vonoprazan versus the 20 milligrams, and then they used a lower dose of lansoprazole. These were pretty, they enrolled a lot of patients. In the first phase, they had about 1,000 patients. And then in the second phase, there was 878. The patients that were enrolled all had endoscopic erosive esophagitis, and they graded it using the Los Angeles grading. If you want more information about that scale, it's outlined in Table 1 on page 230 of the packet. Grade A is the least symptomatic, and grade D is the most symptomatic. They excluded patients that had H. pylori, or if they had Barrett's esophagitis, or an active duodenal or gastric ulcer, or recent GI bleeding, or Zollinger-Ellison syndrome. So they use the intention to treat population for their main assessment. As Kathy pointed out, for non-inferiority, it's preferred to use the per protocol population. But when they looked at the non-inferiority assessment at 8 weeks, the difference was 8.3%, and that was considered significant, statistically significant to show non-inferiority. They had the same results at 24 weeks when they were looking at maintenance, when they compared the 10 milligrams versus the 15 milligrams of lansoprazole, and then the 20 milligrams once a day versus the lansoprazole 15. The FDA went with the approval with the lower dose for the extended duration, most likely because there wasn't any big difference in efficacy between the doses. And if you can use the lower dose for a longer period of time, that makes more sense. We could go to the next slide. So it is a non-inferiority study design, so it's not clear if there's differences in efficacy. We just know that there's no difference in the outcome. There was very few non-white patients that were included in the trial, and like I mentioned, they excluded patients with H. pylori. They did other studies for that. We don't know the impact of treating longer than 24 weeks, and as Kathy mentioned, we don't have long-term safety data for the PCABs on things like that have been seen with the PPIs, like bone fracture, kidney impairment, and C. diff associated diarrhea. We could go to the next slide. In terms of clinical safety, so in the first 8 weeks, it was mostly GI side effects that they observed. On the next slide is the 24-week assessment. And that's when hypertension and UTIs appeared. The longer they used it, that's when they saw the emergence of those adverse effects as well. Next slide, please. Other safety considerations. So this is renally eliminated. So there's quite a bit of information in the prescribing information about people that have GFR less than 30 mils per minute, or if they have moderate to severe hepatic impairment. The dosing needs to be reduced to 10 milligrams a day for the initial 8-week treatment period. It's not recommended to use H. pylori to treat H. pylori in people that have impaired renal function, or if they have impaired hepatic function, because you can't use the 20 milligram dose in those patients. If they have mild hepatic impairment, or if they have a GFR greater than 30 mils per minute, then no dosing is required. The other thing to consider is, because of the extensive hepatic metabolism, there are a lot of drug interactions to consider when using vancomycin, not only because it inhibits the gastric acidity, which can affect absorption of drugs that need to have an acidic environment, but it also works on the CYP3A4 and CYP2C19 enzymes, so it could impact the concentration of those drugs. And conversely, strong or moderate CYP3A inducers can reduce the effectiveness of vancomycin. And finally, we don't have any studies of this drug in pregnant or lactating women or in pediatric patients. Next slide, please. So our recommendation is to maintain the vancomycin dual and triple therapy combinations as non-preferred on the PDL for treatment of H. pylori. And then also maintain vancomycin as non-preferred with some new PA criteria that we've developed just for the potassium competitive acid blockers, because there are some others in the pipeline. I failed to mention these drugs have been used in Asian countries for several years as alternative to PPIs. We'd also like to revise the PPI criteria to remove the assessment of funded and unfunded conditions, and I'll get to that in just a minute. And we have no other changes to the PDL based on the clinical evidence, and we'll look at PPI in H2RA costs and exec session. If we could go to the next slide, I'll go through the PA criteria. So this is the new PCAB PA criteria. So just up to 8 weeks for erosive esophagitis, up to 24 weeks to maintain the healing, 14 days for H. pylori, and then up to 4 weeks for non-erosive GERD. So right now, the only PCAB we have is vancomycin, but like I said, there's others in the pipeline. Next slide, please. So we put this dosing table together just to help with the assessment, because it does vary by indication. Depending on, these are in order of what they had the approval for. So the dose for healing erosive esophagitis, depending on what kind of liver impairment they have, or H. pylori, or if they want to use it for relief of heartburn associated with non-erosive GERD, the 10 milligram dose is what's recommended to use in those patients. Next slide, please. So, oh, I guess the slide that talked about, maybe it's coming up. HERC is removing the guideline note that they have about PPIs at their next meeting. So for that reason, we removed the request to ask if it's a funded condition by HERC, because they're removing that guideline. So we did that for the PCAB PA criteria and the PPI PA criteria. So we start with what's the diagnosis, and then we'll go into, is this request for continuation of therapy that was previously approved? Then the next question is to ask, is it being used for erosive esophagitis? And if it is, have they stepped through a PPI, and are they still having symptoms? If they're still having symptoms, they'll go down to question 6 to assess the baseline renal function. And then in question 5, we're asking if it's being used for treatment of H. pylori. Next slide, please. And then here's the renal function assessment, and then looking to make sure that the dose is appropriate if they do have impaired renal function. And then question 9 asks about the hepatic function, and then going into look at the table to make sure the dosing is appropriate based on what's on the table. And if they meet all the criteria for H. pylori, we'll approve it for 2 weeks, and then for healing, we'll approve it for 8 weeks. And then for the heartburn associated with non-erosive GERD, we'll approve it for 4 weeks. Next slide, please. I think this is just a duplicate. Okay. No, that was going into the maintenance of healing. And then this is the renewal criteria. Yeah, that's what that slide was beforehand. I'm sorry, it's the getting late in the day. So this is just to ask if it's a renewal for maintenance, and we just want to make sure we limit to 24 weeks for maintenance of erosive esophagitis. Thank you, Sarah, for keeping me on track there. So the next slide, I think, talks about the PPI changes. Yeah, I knew I had a slide in there about that, about HERC retiring guideline note. So I just put what the guideline note refers to there. And so they're specific about which indications are covered for PPI treatment. And they're just removing any references to short-term treatment of GERD or long-term PPI therapy. So that's why we didn't include that table in the PCAB PA criteria. And then on the next slide, we talk about removing questions 3 and 4 about asking for the funding diagnosis. And then on the slide after that, we just removed any reference to being funded, because that will be going away from HERC. And then the last table, we've just took out the reference to being funded and instead changed it to recommended by clinical guidelines. With that said, are there any questions about any of the evidence or any of the PA changes? Okay, I think the recommendations are on the next slide. Yeah, yeah.
Good job, Deanna.
Thank you.
So recommendations are in front of you on the slide. Again, to maintain vancomycin dual and triple therapy is non-preferred for the treatment of H. pylori, and to implement the new PA criteria so it can be applied for these agents for the PCABs. Revise the PPI criteria to remove the assessment for the funded and unfunded conditions, and that will also that guideline note won't be in the other PCAB. There's no other clinical recommendations based on the evidence, and we will review these in exec session. Questions about the recommendations, or anybody compelled to make a motion to approve the recommendations?
I think these are well done. I make a motion to approve the recommendations.
Second.
Thank you, Doug and Eddie.
All right, all those in favor?
Aye.
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 Anyone opposed? Abstain? All right, thank you all.
All right, it's time for me to get a radio voice and read a blurb before we go into executive session for the committee and staff. We're going to go to a breakout room for the audience. Bear with us. We will be discussing confidential pricing, and we won't make any decisions, but we'll come back to open session before we deliberate for the final recommendations. So the P&T committee will now meet in executive session for the purpose of consideration of information or records that are exempt from disclosure by law. Executive sessions held pursuant to RS 1926602F and RS 4143561 and 2, which allow the committee to meet in executive session to discuss confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class, that's necessary for the committee to make final recommendations or to comply with the requirements of RS 4143553. Representatives of the news media and designated staff shall be allowed to attend the executive session, and all other members of the audience are not permitted to attend. Representatives of the news media are specifically directed not to disclose any of the deliberations during the executive session except to state the general subject of the session as previously announced. No decision may be made in executive session, and at the end of the executive session, we will return to open session. With that, we'll move into the breakout rooms. All right, turn the recording back on. Making sure I still saw people in the breakout room, but I think everybody's back in the room. Just let me do a quick head count. If committee members can unmute your lines, make sure that we'll prepare ourselves. So I have not only the quorum, but prepare ourselves to take votes. And I'm seeing over there. Fantastic. We have several classes that we went through to do pricing on. Sometimes I lump the recommendations together. I think in this case, since some are more detailed, I'm going to take each class by class. We'll put forward the recommendation for PDL changes. Open it up. If there's conversation or questions, please speak up. If not, we would entertain a motion to approve. So the first is for the Hep C DAA. We had a literature scan as part of the consent agenda. The recommendation of looking at the pricing in exec session is no changes to the PDL are recommended.
Do we have a motion?
Motion to approve.
Thanks, Eddie.
Second.
Appreciate it, Jeannie.
All those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right, thank you.
Also part of the consent agenda were the insulins. We had a literature scan. The recommendations after review are to make insulin Levemir preparations, insulin aspart, so the Novolog and the generics preparations, insulin glulisine, so Pedra preparations, and insulin aspart mix, Novolog mixes and generics. All of those preparations were recommending to be made non-preferred on the PDL.
Do we have a motion?
Motion to approve.
Second.
All right, all those in favor?
Aye.
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 Thank you. Opposed? Abstain? Thank you.
And for the immunoglobulins, we have the scan and DUE. After review and exec, the recommendation is to make Hizentra, Privigen, and GammaGuard liquid preferred, and to make the Gamunex non-preferred, as well as all other agents in the class that didn't previously have PDL status. Those will be designated as non-preferred.
Do we have a motion?
So moved.
Second.
All right, all those in favor?
Aye.
Aye.
Opposed? Abstain? Thank you.
Going to do a mini lump here. So for the multiple sclerosis, DERP summary, and the testosterone for hypogonadism, no changes to the PDL are being recommended.
Do we have a motion?
Motion to approve.
Second.
Thanks, Eddie and Pat.
Thanks. All those in favor?
Aye.
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 Opposed? Abstain? Thank you.
For the inflammatory bowel disease class update, recommendation is to take mesalamine DR tablets, both strengths, preferred agents. No other changes. Discussion or
moved.
motion? Thank you.
Do we have a second?
Second.
Okay, all those in favor?
Aye.
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 Opposed? Abstain? Thank you.
For Duchenne muscular dystrophy, the only recommendation is to make Emflaza, the deflazacort tablets, brand only, preferred, but still require a clinical PA. Discussion or motion?
Motion to approve.
Thank you, Eddie.
Second.
Second.
All right. Did you get that, Roger?
Yep, I got
Okay.
it, Bridget and Pat.
Perfect. All right. All those in favor?
Aye.
Opposed? Abstain? All right. Thank you.
And finally, for the antacid class update and NDE, the recommendation is to make S-omeprazole magnesium capsules, the delayed release capsules, and Talicia preferred, and to designate desks, lansoprazole capsules, delayed release, non-preferred, the BP. Discussion or motion?
So moved.
Second.
All right, all those in favor?
Aye.
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 Opposed? Abstain? Awesome. All right. Thank you all. And
Thank you all. Great job today. A lot of territory we covered. The next P&T meeting is slated for December 5th. I will send out an invitation to make sure and get that on your calendars. Quick reminder, on October 14th, we will be posting the draft materials for that December meeting. Encourage you to look at those draft materials, because that's the time when we can entertain questions, comments, feedback that our team, my authors, can review and consider for inclusion before we post the final documents. So again, October 14th, you're on their listserv. You'll get notification when that's posted. And with that, thank you all very much, and I hope you enjoy the rest of your day.
Yeah, thanks, everybody. Great job.
Thank you.
Thank you.
Thank you.
Thanks.
Thanks, guys.
Thank you.